Shobha, how many facilities are left?
Everybody is logging in. When whoever I'm calling, they're telling we are logging in. Many have already logged in.
Okay. So we will not have any blessings today because the time is less and speakers have to leave for another session.
Yes,
So
madam.
we will straight away start the session.
Yes, madam.
Dr. Madhuri has not joined.
She's joining in few minutes.
Just give me a signal if she joins.
Mattinyaru, Farad Khazni, Zamira Bano.
Election का भी है ना ICOG का. Dr. Madhuri is busy with that.
Rupashri Rashmi Rupamada. Mattinyaru, Dhanlakshmi Itlinva, Triveni Heggeri.
Madam, I have joined.
Okay, madam. Okay. Hello, madam.
Shobha, I'm here.
Namaskara, madam. Madam, most of them have joined and
So we can start now. We can
yes,
start.
madam, we'll start. We have called most of them. Most of them have joined.
So Parulji, you can start now.
Namaskaram and a very good evening to all dignitaries present here today. On behalf of Safe Motherhood Committee FOGSI and Karnataka Society of Obstetrics and Gynecology, I extend a very warm welcome to our esteemed faculty and delegates who have joined today in this wonderful journey called Scaling FOGSI Vistrit in Karnataka, a technical engagement for accelerating safe motherhood, an initiative by SMC FOGSI and KASOGA to provide focused trainings on anemia, GDM, and hypertensive disorders of pregnancy.
Anita, madam.
With great humility and pride, we say that SMC FOGSI, under the able leadership of its chairperson and the constant determined efforts of our chairperson, Dr. Preeti Kumar, have been able to successfully finish our trainings on these subjects to 29 facilities, more than 350 healthcare workers of Karnataka. And the results are already visible in their confidence while dealing with patients. So now is the time to brush up the knowledge of our esteemed doctors by none other than our learned stalwarts of FOGSI, in turn bringing comfort to so many mothers and reducing maternal mortality. On this auspicious beginning, let us now invoke the blessings of Almighty by lighting the lamp of knowledge. I request all leading lights of Safe Motherhood Committee FOGSI and KASOGA to join hands and to revive the lights. Arun?
Kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah Shatru buddhi vinashaya Deepajyotirnamostute Deepajyotirnamostute Shubham kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah.
Dr. Madhuri has not been able to join?
No, I don't see her in the participants list.
But she gave her blessings to us. Thank you, ma'am.
I'm there. I joined back.
Thank you, Dr. Vidya. Thank you.
We now start with the scientific deliberations of the day. For this, I call upon our respected chairpersons, Dr. Vidya Thobi, ma'am. She is the President KASOGA, the Professor and Head OBGYN, Alamein Medical College, Vijayapur. And we are blessed to have the constant supervision, encouragement, and guidance from her. Thank you. The other chairperson is Dr. Rajshri Paladi, another backbone of this project. She is the dynamic General Secretary, Kasoga, and also the director at Aditya Multi-Speciality Hospital and Professor OBGYN at KBN University, Gulbarga, Karnataka. Our third chairperson doesn't need any introduction. She is the backbone and everything for these programs. Dr. Preeti Kumar, who is the chairperson of Safe Motherhood Committee, FOGSI. Over to the chairpersons to start the session. Dr. Vidya ma'am, please introduce the first speaker.
Yes.
Dr. Jyotsna.
Dr. Jyotsna Suri.
Yeah.
Can I share the screen with the permission of the chair?
Yes.
Yeah.
It is a pleasure to introduce Dr. Jyotsna Suri, who is a professor and unit head and in charge of critical care obstetrics at VV, PMMC and so she is going to talk to us on fluid in preeclampsia and eclampsia. So over to Dr. Jyotsna Suri, and let us listen about the fluid management in the cases of preeclampsia and eclampsia. Thank you very much.
I don't know, the wrong thing is being.
क्या हुआ जोत्सना जी?
1 minute. जो मैं शेयर कर रही हूँ ना स्लाइड, वो शेयर नहीं हो रही. Something else is coming. Just a moment. I don't know what is happening.
No, madam. Fluids and preeclampsia only was there.
Is this there?
Yes, madam. That was visible.
Yes, it's the same.
Is it visible right now?
No,
No,
not
now it is
visible.
not.
Okay,
Now
I'll
it's
share
not
it again.
sharing.
I'll share it again. 1 minute. I could see something else actually. So yes, so you can see this now?
Yes. Make it full screen, Jyotsna ji.
I am making it full screen. Okay. Yes, so thank you very much, Dr. Preeti, and for giving me this opportunity and for this wonderful initiative which you are doing. So the topic for today is the fluid management in eclampsia and pre-eclampsia. So 1 minute. So I'll start with a case presentation quickly about one of the cases which we managed. So this case was Mrs. A, 23-year-old. 1 minute, yeah. I'm actually getting disturbed by this on the right side, the panel. I'm trying to remove it. It's not going. 1 minute.
Jyotsna ji, just stop sharing and then minimize the presentation. Minimize that view on the top. Or make it speaker on speaker mode.
नहीं, वो छोटा नहीं हो रहा. वो जो साइड में पैनल
एक बार शेयर कर लिया तब नहीं होगा.
तब नहीं होगा.
नहीं, तब नहीं होगा.
होता तो है वैसे normally. I don't know, इसमें नहीं हो रहा. But दोबारा I'll just be wasting actually because okay, चलो I've brought it to the other side. Yeah. Okay. So now I can see my screen clearly. Yes. So Mrs. A, 23 years, primary at 37 weeks, underwent elective LSCS for twin pregnancy with severe preeclampsia under spinal anesthesia, and 1 liter of ringer lactate was given to her for preloading. Her cesarean was uneventful. In the recovery room, the patient developed shortness of breath, and on examination, she was irritable and not responding to verbal commands. Her respiratory rate had increased to 28 per minute, and her pulse rate was 110 per minute. BP was 160, 110. JVP was not raised. She had edema feet, of course, and there were basal crepes, fine crepes, So the SpO2 had become 85% in spite of the fact that she was on the face mask at 8 liter per minute. And her pH also showed metabolic acidemia. So, yes. Okay. So she was immediately intubated and put on positive pressure ventilation along with injection Lasix 40 milligram and was transferred to the ICU. So this was the case, which actually is a genuine case in our hospital. And all the participants who are today here, I'm sure they may have guessed that what was the diagnosis and what had gone wrong. So basically what had happened that the patient had gone into a pulmonary edema post cesarean. And so now we'll just quickly revise that what are the chief causes of maternal mortality in pre-eclampsia and eclampsia. The first and foremost, most important cause is pulmonary edema, which is to quite some extent a preventable cause. Then, of course, there can be the cerebrovascular accidents and the acute renal failure. Pulmonary edema is now recognized as the most common final cause of death in women with complications of hypertension. This was the Saving Mother document released in 2008 and 10, following the UK audit. And what is the reason? Why do these women go into pulmonary edema? So you can see first and foremost, they have an increased preload. And what is the reason just after delivery? Why is it more in the postpartum period and especially after a cesarean section? Because of one of the most important reasons is excessive IV fluid administration. And second is the resolving purpureal peripheral edema after the delivery. Then there could be a cardiac cause like a coexisting diastolic dysfunction or even a cardiomyopathy or any other valvular heart disease. Increased afterload in with the severe hypertension can lead to the increased systemic vascular resistance and increases the propensity for developing pulmonary edema. In our case, the BP was also very high, 160, 110. Other factors which are very, very important for us to remember. One is the reduced oncotic pressure in pregnancy because of the low albumin levels. Mainly, that is the chief reason. And this is there in all pregnancies. So remember that to some extent, all pregnancies are, at a risk to develop pulmonary edema, but more so the pre-eclampsia, eclampsia. And that is because they all have endothelial dysfunction, which is one of the main pathogenic, mechanisms for developing the pre-eclampsia, eclampsia syndrome, leading to increased capillary permeability. So I think I have explained that what all are the reasons for pulmonary edema, especially in the postpartum period. So 70% of all pulmonary edemas are seen in the postpartum period. So what are the basically indications of fluid in pre-eclampsia, eclampsia? So one will be the maintenance fluids. The second is the replacement or the resuscitative fluid. And third is the fluid which is given as a preloading just before the cesarean section and the regional anesthesia. So maintenance fluid normally is only given if the patient is nil by mouth, during the perioperative period. So 60 to 80 ml of crystalloid is what is recommended. But remember that if you are giving other drugs through the IV route, magnesium sulfate, some of the drugs like metronidazole, the paracetamol infusion, all of them have got some volume. So don't forget to calculate that also in your 60 to 80 ml per hour. So this means that all fluid which is given should amount to that. Then the replacement or the resuscitative fluid. So what are the indications? I'll just tell you in the next slide. We do give crystalloids as the primary resuscitative fluid, and sometimes we may give colloid also. And then the third is the preloading. So preloading, it is recommended that we should not give more than 300 ml of crystalloid before the regional anesthesia in pre-eclampsia cases, because we know that, when we give the regional anesthesia, there will be some vasodilatation, and there, because of that, there is hypotension, and they always give the fluid, the anesthesiology colleagues, they will give preload with the fluid. So here they have to be very cautious. So the reasons why we, need to give the resuscitative fluid in patients with preeclampsia. So the main important reasons I have just written, that the women with preeclampsia, eclampsia are more prone to abruption. They may go into hypovolemic shock because of that. Then there may be PPH. They are more prone to PPH. They may have the rare complication of HELP with liver rupture. They may have a coagulopathy, again leading to bleeding, or they may have any other reason for hypovolemic shock like a placenta previa or placenta creta syndrome, or they may have septic shock. So these are the common conditions in which the patient will need fluid resuscitation. The purpose is that we have to restore the euvolemia, increase the oxygen carrying capacity, and correct the coagulopathy. So euvolemia, you can, to some extent with fluid, you can increase. But for oxygen carrying capacity, if the patient has lost a lot of blood, you need to give the packed RBCs. And to correct coagulopathy, you have to give the FFP or the cryoprecipitate or the platelets if the patient has got a thrombocytopenia. So when you are giving, now our concern is mainly, that we don't want our patient to get fluid overloaded and develop pulmonary edema, as I told you in the introductory slides. So how do we monitor the fluid when we are giving? Because it is very often that we need to give this kind of fluid resuscitation to the preeclampsia, eclampsia patients. So how do we monitor? So the first is the conventional method, and that is by checking the pulse, blood pressure, urine output, and saturation. So now here, again, the catch is that many of the preeclamptic women already have got, renal condition, they have a renal failure or their output is low, so they will not make urine, not just because of the pre-renal, but due to the renal cause of AKI. So their kidneys are already affected due to the pathology of preeclampsia, eclampsia.
I think we lost connection.
Yes. Jyotsna madam, can you switch off your video? Maybe your voice may come. Lost the connection totally.
Connection problem. I'll call her again.
Yeah. Sorry, I
Now she's connecting.
took to the other one. Yeah. Can you hear?
Yes, Jyotsna ji, but share your slides again.
I'll do that. Yes. Can you see?
The previous one, I think you were speaking on the previous one.
This one I was speaking.
Yes.
Yes. So now I'll be just talking briefly about the hemodynamic, the CVP and the pulmonary artery wedge pressure, that why it is not a good method for monitoring the fluid responsiveness in cases of preeclampsia. So basically what happens that a CVP line provides the right atrial pressure measurements, we all know that, and it is a static test with a poor correlation to the blood volume. In pre-eclamptic women, if we keep monitoring the CVP and see the CVP pressure, we will end up giving more fluid, because once we are giving boluses of fluid, it leads to sharp increase in the pulmonary capillary wedge pressure increase before there is a rise in the CVP. And this sharp rise in the pulmonary capillary wedge pressure may precipitate pulmonary edema due to the increased hydrostatic pressure in the pulmonary vascular bed. So CVP monitoring is not considered to be very useful because we may, in fact, if we follow the CVP, we may end up with the pulmonary edema. We may give more fluid. Insertion of pulmonary artery catheters is a very challenging task. Only the best of the critical care physicians are, experienced in this art, and it does have its own risks of morbidity and even mortality in the procedure. So we are actually, the non-invasive methods are actually very good methods, except for very few conditions in which the patient is in absolute oliguria, anuria, and you really need the invasive method. We can do with these methods, which are the non-invasive method. So non-invasive method can be a clinical based method or through the ultrasound. So the first I'm going to tell you, it is a dynamic test of fluid responsiveness. That is the passive leg raising test. So in a spontaneously breathing patient means that she is not on ventilator. An increase in the pulse pressure of 9% or more. The pulse pressure is SBP, systolic blood pressure, minus diastolic pressure. On the passive leg raising for 3 to 4 minutes is an indicator of fluid responsiveness. So just when you are giving the boluses of fluid, you want to give 500 ml bolus or 1 liter. Before you give, you do this simple test, raise her foot end for 3 minutes, see the change in the pulse pressure. If it has changed between A and B position by more than 9%, then you can give her a bolus of fluid safely. The other test is the, IVC collapsibility. So inferior vena cava or, collapses more than 50% if it is during inspiration, if there is fluid responsiveness. So if the IVC diameter is more than 2.5 centimeter and there is no collapsibility during inspiration, this patient should not be, given fluid. She can go into pulmonary edema easily. This is the cardiac probe, which we just place 3 centimeter from the right atrium while we are doing the ultrasound. Very, very simple to do, very easy to learn. So you can see, you can appreciate here. This is the collapsible IVC. You can see that when the patient, you can see this is the right atrium and how it is collapsing. And here you see the IVC here, there is no collapsibility. So this patient is not fluid responsive at all. If you give fluid to such a patient, you will end up with more serious problems. So this is the one test we normally are doing. Then the next one you can do, another non-invasive test is you do the lung ultrasound and see the B lines. So if the B lines are there, that means that the patient is already in a state of fluid overload and you should not give. So this is again, these B lines are these linear lines, which you see, hyperechoic linear from, this is the pleura, and you can see they are arising from the pleura, and they are signifying that the patient is having early pulmonary edema already in this case. So these are methods which you can be trained into. They are very simple to learn with your ultrasound machine. You have to learn it through with your colleagues, the anesthesia colleagues. I'm sure they can teach you, and you can, then monitor your patient very easily. Now, which fluid to give? Is it crystalloid or is it colloid? So it is always crystalloid which we give initially, because crystalloid is the, all evidence says that they are the best fluid to give the fluid resuscitation. The important thing to remember that they have low tendency to stay intravascular because almost 2/3 of it goes into the interstitial space. So we cannot keep giving crystalloid, without knowing how much we have given. So up to 2 to 2.5 liter is the upper limit, and that too with in preeclampsia, even 2 liter may be too much. You may have to keep monitoring with your passive leg raising test and with your lung ultrasound and even with the inferior vena cava collapsibility. Now the colloids, they have a high tendency to stay intravascular because of the larger molecules. They exert greater oncotic pressure. But again, problem with colloids are that, colloids, there is a very high risk of anaphylaxis, and there are, coagulopathy is one thing which is very commonly seen with the colloids. With hydroxyethyl starch, you can actually cause acute kidney injury, and eventually these large solutes also enter the interstitial space and hold a lot of water, leading to pulmonary edema. So this chart I have put here only for you all to realize that the sodium chloride and lactated ringer, they are good fluids. Lactated ringer is closest to the plasma, whereas dextrose is just a D5W, which has got only dextrose and no other solute. And as soon as the dextrose is metabolized, it remains only free water, which can just go into all the organs and lead to pulmonary edema as well as brain edema, especially in preeclampsia. So please don't give D5W ever for fluid resuscitation. It can be given only in some circumstances. If the patient has got hypoglycemia, we prefer 10D or 25D or some other conditions, which may require D5W. But otherwise, it is not a common fluid which you should be given in your labor rooms. Now, out of the two for fluid resuscitation, which is better, NS or RL? Both of them are equivalent. Only remember that normal saline, if you give more than 2 liters, there may be some risk of renal dysfunction. And saline is cheaper and more widely available. So we are not really worried because normally we don't give more than 2 liters in such circumstances. Then if your blood products have not come, there is PPH, you would shift over to colloid after 2 liters of crystalloid. Ringer lactate is more physiological, definitely got a better composition, closer to plasma. But if you are giving it, just be aware that there is some potassium in this, 4 milliequivalent per liter, which saline doesn't have. So this is one thing you have to remember. In hyperkalemia, it is relatively contraindicated. And if you are giving it along with the blood in the same line, the calcium in the ringer lactate can bind and cause chelation. So always give it through the separate lines. So the dilemma here that if you keep the lungs happy, you may, that is a dry lung, you may end up with poor perfusion to the kidney. So it is important for us by doing the proper non-invasive, tests to give the adequate fluid. Don't deny her that, but don't end up with pulmonary edema and don't end up with acute kidney injury. Be in this middle part. So this is, very, very important. A word or two about maintenance fluid in the perioperative period. So in women with eclampsia and those who have a poor GCS means that they are not, conscious, fully conscious. They are in delirium. They are, don't give oral feeds in this state. They can aspirate. So here we have to rely on fluids for a short term. So rate is maximum 1 ml per kg body weight per hour, inclusive of all fluids I told you. Normally it will be about 50 to 80 ml per hour. Which fluid to give? So remember this, that they require sodium per day of 2 milliequivalent per kg body weight, potassium 1 milliequivalent per kg body weight, and dextrose per day is 50 to 100 gram per day to prevent the starvation ketoacidosis. So again, this chart I have put here for you all to, recapitulate that which are the fluids which we are giving. So the best fluid which you can give is, the fluid for maintenance is the half DNS, which will have the right amount of sodium, sodium and glucose. Potassium, none of the fluid has got enough. Even if you give RL, it is too low. So you have to add 20 milliequivalent of KCl in each of the VAC which you are giving. So this is important. If you are giving IV fluid for more than 24 hours, you should always replace potassium because no other fluid, their potassium requirement will not be met. And of course, keep monitoring the electrolytes. If your patient is going into the AKI or something and her potassium is already on higher side, we would not recommend that you give potassium in the fluid. Now the final slide, what does the guidelines say? The NICE 2009 do not preload women who have severe preeclampsia with intravenous fluids before establishing the low dose epidural analgesia or combined spinal epidural analgesia. Number 2, do not use volume expansion in women with severe preeclampsia unless hydralazine is the antenatal antihypertensive. Number 3, in women with severe preeclampsia, limit maintenance fluid to 80 ml per hour unless there are other ongoing fluid losses, for example, hemorrhage, in which case you will use the fluid as a resuscitative fluid, which we discussed. And FIGO also says similarly, the same 80 ml per hour, and fluid should not be routinely administered to treat oliguria, that is urine less than 15 ml per hour for more than 16 hours. And for treatment of persistent oliguria, neither dopamine nor furosemide is recommended. So the final concluding slide, there remains little evidence on which to base the ideal fluid management strategy in the parturient with preeclampsia. Fluid management should be tailored to individual patient with the aid of clinical assessment and where available in complicated cases, non-invasive modalities of hemodynamic measurements such as lung ultrasound, transthoracic echocardiography, or pulse waveform monitors. And in the absence of specialized monitoring of intravascular volume in the individual case, and in view of the multifactorial etiology of pulmonary edema, a continued policy of fluid restriction as proposed by the NICE guidelines is justified. And of course, we need large RCTs about, exactly the influence of fluid management on the patient outcome. So these are the references, especially this Saving Mother is a very important document which was released after the confidential inquiries into maternal deaths in South Africa. So thank you very much for the patient hearing.
Excellent talk, Dr. Joseph. Dr. Vidya, are you there? Dr. Vidya? So thank you, Dr. Jyotsna. I think Dr. Vidya lost the connection. Excellent presentation as always. You very well covered about the maintenance and resuscitative fluids. And we have patients die for preeclampsia, and I think the participants alert a lot.
Thank you, Dr.
Now we can move on to the next speaker. Thank you so much, Dr. Jyotsna. Introduce the next speaker, Dr. Prakash sir.
Yeah, ready.
Dr. Rashri,
Yes, ma'am.
please introduce
Yes,
Dr. Prakash sir.
Good afternoon, everybody, and welcome to this session of being taught by the masters of the management of preeclampsia. We just now heard a very wonderful talk by Dr. Jyotsna about the fluid management, and next we move on to another expert in the subject, Dr. Prakash Mehta, who is very familiar to all of us in his dealing with high-risk obstetric pregnancy. And it is my proud privilege to introduce Dr. Prakash Mehta, who is the Chief Division of Maternal Fetal Medicine and Head of Department of OBGYN at Bhagwan Mahavir Jain Hospital, Bengaluru. Postgraduate and PG Fellowship Teacher and Examiner in Maternal Fetal Medicine in OBGYN. Numerous articles in various journals, contributed to chapters on maternal fetal medicine in many books, delivered oration in field of maternal and fetal medicine at various places, President, Society for Maternal Fetal Medicine India, organizing chairperson for ISSHP 2023 World Congress, past president of the Bangalore OBGYN Society, past joint secretary at FOGSI, coordinator for FOGSI UNICEF protocols in obstetrics and luxury mentorship, best teacher award, Bangalore OBG Society 2020, and lifetime achievement award honored on him by BSOG 2021 in Karnataka. So he's been a very wonderful teacher, and we would love to hear from him more about this very enticing subject and challenging topic. Over to you, Prakash sir.
Thank you very much for that kind introduction. I have to thank Dr. Preeti Kumar as well as our own Kasoga for having me here, so that I could just share whatever little I know about this particular subject. So today's topic for deliberation would be HELP syndrome. Okay, now whenever you have a HELP syndrome, palpitations have to occur. Without that, you cannot have a HELP syndrome, because the trouble it gives you and to your patient is a little too much, quite often difficult to handle. So before I go further, I would just like all our audience to answer the question to themselves and then try to see whether the answers were correct or not, or in what way they can change at the end of this lecture. So the first question is, in your practice, whom do you order platelet counts for? Is it for all pregnant patients, or generally I don't order platelet count, all hypertensive pregnancies, or only in patients with severe hypertension?
Sorry to interrupt, sir. Can you make it full screen, sir?
I thought it was full screen. No?
I don't think so, sir.
No, sir, it is not full screen.
No, it's in the slideshow.
No, sir.
It's in the slideshow.
It is, because that's what I thought so. Okay, how about now?
No.
It's not full screen?
No.
No, sir, it's not.
Okay, what I'll do
Put
is
it in the slide show, sir.
Slide nahi aa raha hai.
Koi baat nahi, continue, sir, then.
Yeah.
Don't
Okay,
worry.
do you order LDH estimation on your hypertensive patients? The answer is no. Yes, on all patients, occasionally, and not a part of liver function test in my lab.
Yes.
And the final question that you need to answer to yourself is, what do you do when a patient telephones with complaint of epigastric pain at 26 weeks of gestation? Prescribe antacids on an outpatient basis, refer to medicine department, ask her to come in for admission, or ask her to come to the office for detailed examination and investigations. Okay, so let's see if there is any change in the answers that you have given at the end of the lecture. Now remember that sometimes in life everything goes smoothly and sometimes the unexpected happens. All of us have had this experience when you were in a middle school or primary school, and the exam, exactly as you're answering a question, your pencil would break into two. But also remember that the chance favors the prepared mind. And I really congratulate both Dr. Preeti and the Kasoga team for arranging this kind of a preparedness program.
Sir, excuse me, sir. Slides are not moving,
Sir,
sir.
change, sir.
Okay, I'll stop sharing and then we'll go further. I'll
Yes.
reshare.
Yeah.
Yes, sir.
Okay, is it share? See,
It is full screen, sir, now.
it's all right.
Yes, sir. Fine, sir. Now.
Fine. So let us first understand what is HELP syndrome. HELP syndrome has got three aspects to it. The H standing for hemolysis, EL standing for elevated liver enzymes, and LP standing for low platelet count. It does not mean that the HELP is going to show you all the three features. You can have one or two or all the three features depending on the case. I don't know what's happening. Okay. The incidence, now look at the incidence, it's only 0.2 to 0.6% of all pregnancies. That means if you see about 1,000 cases of pregnancy, you are likely to come across HELP syndrome only in 2 of them. Then why are we trying to give so much emphasis to such a rare occurrence of this particular disease? We'll understand that as we move along. Now, the distribution of HELP is that antepartum accounts for about 70% of the cases. But at the same time, you need to remember that for at less than 27, we have 11 incidents. More important to remember is that HELP occurs for the first time in the postpartum period in 30% of the cases. That means you have not even suspected it before you delivered her that this patient has had HELP syndrome, but you realize that only after the delivery is over. Now, the American College of OBGYN has given clear-cut features for its diagnosis. LDH greater than 600 international units per liter, AST and ALT elevated. It should be twice the upper limit of the normal for your lab. Remember, AST, ALT values can differ from lab to lab. So whatever is the value in your lab, if it is more than double, then consider it as elevated liver enzymes. And finally, the platelet count, which is less than 100,000. Now, the ISHIP is the process of changing these guidelines from 100,000 to 150,000. So any platelets lesser than 150,000 in future will be considered as low platelet count. Overall, what we need to remember is that the severity of the HELP syndrome is reflected in its laboratory parameters and not in the clinical parameters of blood pressure and proteinuria that we are so used to in a patient with preeclampsia. If the blood pressure is high, we get worried. If the albumin becomes 4+, we get worried. But for HELP syndrome, you may not have albumin at all. Her blood pressure may just be 130/90, which is not going to disturb you in any way. But the laboratory parameters could be grossly abnormal and patient could land up with a severe problem. Classification, just to complete, it's more theoretical, but we should know a little bit about it. So we have basically two classifications, the Tennessee classification and the Mississippi classification. Tennessee classification depends on the number of abnormalities that are present. So if all the three abnormalities are present, you call it full HELP. If only one or two of them are present, you call it as partial HELP. Now remember that the partial HELP could be a stage in the evolution of HELP syndrome and would soon become a complete HELP syndrome over a period of time. The Mississippi classification is based on the platelet nadir or the platelet count. If the platelet count is between 100 and 150,000, you're going to call it as class 3. But if it is less than 50,000, you're going to call it class 1. So obviously, because of based on this platelet count, we can clearly understand that if you have a class 1 HELP or if you have a full HELP, the complications that the patient is going to have is going to be much more than if she belongs to class 3 or she belongs to a partial HELP. Now, basically, the HELP syndrome has its own pathophysiology. As we know that there is vasospasm in preeclampsia, but this vasospasm in HELP syndrome is associated with much more endothelial dysfunction than in a routine preeclampsia. Now, once there is an endothelial dysfunction, automatically platelet aggregation is going to occur. And we know that whenever platelet aggregation occurs, a consumption of platelets starts, and we get the condition called as MAHA, NAHA, or the microangiopathic hemolytic anemia. Because once the platelets break, the RBCs are going to be also caught in that mesh, and RBCs are also going to be destroyed. So you will have a condition of thrombocytopenia, and you'll have a condition of anemia due to hemolysis. And because of these factors, a selective organ ischemia can occur. Again, which organ ischemia is more depends on an individual basis. Like in some patients, it could affect lungs more. In some patients, affect kidneys more. In occasional patients, it will affect pancreas, causing a kind of a pancreatitis with HELP syndrome. So which organ it affects depends on ultimately the way the patient has a reaction to the HELP syndrome. And because of all these factors, there's a diverse symptomatology. So, you know, really, I don't have I can't pass a statement saying that if you have 1, 2, 3, it is HELP syndrome. No, the symptomatology is very diverse. Now, whenever you are suspecting a HELP syndrome or have a patient with HELP syndrome, investigations are very, very important. And the common investigations that we do are hematocrit. I do not know how many of you are really doing a Paxil volume when you order a blood test, because I've seen quite often in my referral practice that is only HB% is done. Please remember, HB% without a Paxil volume figure is absolutely useless, doesn't give us any information whatsoever. So you need a PCV to understand why that HB is 6 grams or why that HB is 14 grams. You need the PCV. You need to do a peripheral smear. You need to do a the platelet counts, liver enzymes, the uric acid estimation. And of course, now we do a lot of biomarkers to understand the prognosis. You can do an S-split PLGF ratio if it is available, or you can do a glycosylated fibronectin, which is a point of care test if that is available with you. Now, if you don't have biomarkers, please don't worry, because the amount, if you are doing your investigations properly, and if you're interpreting your investigations properly, it gives you enough clues as to how severe the disease is. But remember that proteinuria may be a late manifestation. You may not have proteinuria at all in a patient with HELLP syndrome. So don't depend on it. Now we get a lot of complications with HELLP syndrome, starting from ICU care to hemolysis to accidental hemorrhage, liver hematomas, which is quite often, ends up with a mortality, cerebral hemorrhage, again a very important cause of mortality. You can have an AKI, that is acute kidney injury, a DIC resulting in bleeding from every side that you can think of, and of course pulmonary edema is quite common in these conditions. It's not that just the mother is affected, even the fetus is affected. For the fetus, you have a decreased uteroplacental perfusion, which could result in an IUGR and an oligamnios. Placental abruption is very common. Please make it a point to look for HELLP syndrome in every placental abruption case that you see. I'm not telling you that all 100% placental abruptions are due to HELLP syndrome, but many of them, rather I would say more than 50% of them, are associated with HELLP syndrome. And so if you have a placental abruption, definitely do all the tests to rule out HELLP syndrome, even though there may be no protein or even though the blood pressure is normal. And of course, because the HELLP syndrome requires delivery, preterm labor and delivery and its complications are very common in these patients. Now, HELLP syndrome, we have various differential diagnoses. I'm not going to go into too much detail of it, but just remember that there are certain conditions called as acute fatty liver of pregnancy, the short form being AFLP. But if it's a patient with AFLP, the hepatic features will overshadow all other features. Or it could be what we call as a TTP or a thrombotic thrombocytopenic purpura. Those from Karnataka would understand that, whenever a patient gives you too much trouble, they call them TTP, Tale no patient. So, but this TTP is paletinoing for you, not for the patient. So here the most common features are the hematological features. And then we have what is called as the hemolytic uremic syndrome or an HUS, where the renal features will overshadow all other features. And finally, remember that other conditions like SLE, believe me, I've picked up SLE in many patients with HELLP syndrome because they were not identified before. And remember that the treatment of SLE is much different as compared to a treatment of a simple HELLP syndrome. So SLE has to be ruled out. Viral hepatitis could be one of the differential diagnoses because the patient has come with elevated liver enzymes, low platelet count. So viral hepatitis has to be ruled out, and finally gallbladder disease. I'm just going to take you to one or two cases to see how we handle these cases. Now the management, of course, you cannot manage HELLP syndrome in an archaic situation. If you are not having all facilities with you, please do not keep a patient with HELLP syndrome with you. Transfer her to the nearest tertiary care center, maybe the nearest district hospital or the nearest medical college hospital. Do not keep them with you because you cannot manage a patient with HELLP syndrome in a small center. And remember that the multidisciplinary approach in a tertiary care center where everything from dialysis to ventilation is available, it is those places where they have to manage a HELLP syndrome. So with this, we'll quickly go through one or two cases which are perplexed me in diagnosis. Now, this first case was one of my first HELLP syndromes, which I came across in my life. This is long back, of course. This was a story of Mrs. D, a 24-year-old, gravida 2, abortion 1. At 32 weeks of gestation, she came with history of mild rise in blood pressure and right hypochondriac pain. Now, this patient, as usual, common in our situation, was going to her mother's house for delivery. So she had come to me for a check only about 1 week back. She was, and before actually going to the airport to travel to her mother's place, the couple had gone to a temple to pray God before leaving her in-laws' place. And in the temple, she developed severe upper abdominal pain. So that is the time when they called me and I asked them to rush to the hospital immediately. Now, remember, this patient was apparently well so far. There was nothing that was wrong with her. And even on admission, the BP was only 140/90, nothing more than that. But she had also vomited 3 times. Now, I told you already that this was one of my first cases, and we did an ultrasound scan, and you can see the ultrasound scan, you can see that there is a gallbladder wall thickening. So the first thought that came to my mind at that time was acute cholecystitis resulting in pain. Okay, now today, after so much of experience, if I see any patient with this kind of a gallbladder picture, without hesitation, I label them as health syndrome. And so far, not to boast, but so far, I've been right 100% of times. So if you see a picture where there is a gallbladder wall edema, straight away make a diagnosis of health syndrome and then try to prospectively prove whether you are right or wrong. Now, so the attending surgeon said she has got cholecystitis. I think we need to operate on her. So start getting ready for surgery. But at the same time, when I did the scan, there was a fetal growth restriction. So this started disturbing me a little bit. Why are there some kind of obstetric issues in this patient? Now, mind you, this case is what I had managed in 1991 or 1992. And you know, health syndrome came into being only around 1984 when Weinstein first time came up with the health syndrome. So, but something was disturbing me. Why is this patient behaving like this? So within the next few minutes,
Hello.
after getting her ready, the patient threw convulsions. And by the time the results came in, the platelet count were 80,000 and liver enzymes were elevated. Immediately, I told my surgical colleague, look, this is not your field, this is my field, and I'm going to take her up for a C-section immediately. When I opened her up, there was already ascites with blood-stained fluid. There was accidental hemorrhage with cuvellar uterus. A 1.2 kg male baby with poor Apgar was delivered and shifted to neonatal intensive care, where he died after 5 days. Cesarean section was otherwise uneventful, but mother continued to throw convulsions in spite of magnesium sulfate, and as the hypertension persisted, a nitroglycerin drip was started. Because she was throwing continuous convulsions, we had to paralyze her and put her on a ventilator. And about 6 hours after surgery, she manifested with a full-blown DIC, with bleeding from nose, gums, subconjunctival hemorrhage, and so on. Her urine output was, however, well maintained throughout this period. I had to give her 10 units of transfusion. And in spite of a very stormy post-operative period, I almost didn't sleep for 4 nights. Patient recovered in about 72 hours after delivery and was discharged at 10 days. Now, whenever I talk of health syndrome, I invariably like to bring out this case because this is the real situation which I have gone through. And I don't want anyone else to go through this kind of a situation. Now, the second case behaved a little differently. She was a 22-year-old gravida 2 paraben living 0. She had a history of severe preeclampsia during the first pregnancy, resulting in a cesarean section at 28 weeks of delivery of a dead 800-gram male baby. This was done outside. Her current pregnancy was uneventful, except for a mild increase in blood pressure from 33 weeks, a mild fetal growth restriction. At 36 weeks, her non-stress test was non-reactive, and that doctor referred her off to me, saying that I'm uneasy about handling this case, sir, you please handle it. So once she came to me, we did a C-section. The blood pressure at the time of surgery was 140/90 with mild fetal edema and 1+ albuminuria. I'm sure you will agree with me that this kind of a picture doesn't disturb you one bit. We see such cases day in and day out. A 2.4 kg live female baby was delivered, no neonatal problems. Surgery was otherwise uneventful. But look what happened later. About 9 hours after surgery, decreased urine output was noted, which did not respond to fluid challenge. 12 hours after surgery, there was zero urine output. And a diagnosis of acute kidney injury or AKI was made. We don't now call it that condition as acute renal failure or ARF and CRF or chronic renal failure. The terminology has changed and we use the terminology of AKI. At that time, her platelets count was 30,000. The liver enzymes were raised. The picture showed a very clear-cut hemolysis on peripheral smear. HB% dropped to 6 grams from the preoperative level of 11 grams. A diagnosis of HELLP syndrome with renal failure and liver necrosis was made. And in view of rising creatinine and potassium levels, she was dialyzed. Patient improved. In the next 14 hours, 18 units of blood and blood products were transfused. She improved symptomatically in about 72 hours, but the renal failure persisted. By the end of second week, the urine output started improving. And at the end of third week, the patient was absolutely fine with normal renal function. 2 years later, she again became pregnant and underwent an NTP because she was scared what would happen. She didn't come to me. She went to a nearby gynecologist and ordered termination for her. And 1 more year later, she became pregnant again. And this time she continued the pregnancy and came back to me, monitored her closely, did LSCS at 35 weeks for early IUGR and oligamenous with mildly raised blood pressure. Preeclampsia profile was normal, female baby, 2 kgs, there were no problems. And then I insisted and counseled them for a tubectomy. I said, no more pregnancies for you, this is enough. And we did a family planning operation at the time of C-section. Now, the case 3 was a 28-year-old primary gravida referred with severe PPH 8 hours after spontaneous vaginal delivery. She had regular ANCs. Occasionally, her blood pressure would touch 140/90, but it was ignored. Then what happens? Okay, it happens sometimes. You're anxious. That's why your BP is 140/90. Okay, and it was ignored. When she came to me, her general condition was poor. She was severely pale. She was icteric also. Pulse was 120. BP was 90 systolic. Diastolic could not be recorded. Uterus was 20 weeks, well contracted. But there was that packed the vagina. And through the pack, there was a lot of bleeding occurring. Remember, so far, she was not catheterized. I would like to remind all our delegates over here that whenever you have a preeclampsia severe or whenever you have a PTH, first thing that you need to do is to catheterize the patient. Please do not shift her without catheterization. So when we catheterized in my emergency room, there was 100 ml of bloody urine that came out. Did a bedside ultrasound scan, there was no evidence of retained placenta. So you can see this is a scan and you can see the pack that is sitting in the vagina, the white hyperechoic area. So she was taken up for an emergency exploration. There was cervical and vaginal tears. This suturing was done. She was bleeding heavily through these tears because she was in HELLP syndrome. So that is why she was bleeding heavily. A routine patient might not have bled so heavily and it would have been easy to suture. All of us suture cervical tears and vaginal tears almost every other day. So that wouldn't have been an issue. But because she was in HELLP syndrome, this tears gave her a lot of trouble. Of course, prophylactic magnesium sulfate was given. Remember, HELLP syndrome is a kind of severe preeclampsia. And for all severe preeclampsias, we have to give a full dose of magnesium sulfate. After suturing, I packed her up again and pack was removed after 24 hours. Now the bleeding was within normal limits. I had to give her 11 transfusions in this period and patient was discharged on day 5. And this start just to see how she behaved, how her investigations behave. Because when you have a HELLP syndrome, you need to do repeated investigations and you need to see how the trend of investigations happen. So you can see the serum albumin going up, the serum creat was initially 1.1. That was because she was in hemodilution. And AST, ALT, how they changed. You can see here that the AST, ALT increased in the initial delivery period, after delivery period. So remember, the HELLP syndrome is something that is going to worsen after delivery. So do not ever reassure a patient that if I deliver, the patient is going to be all right. So the lesson learned from these cases and some of the other cases that I've handled is that wrong diagnosis is a possibility in HELLP syndrome because of non-specific symptoms. HELLP need not be accompanied by severe hypertension. A mild increase in hypertension can trigger it. If you have a patient with unexplained postpartum hemorrhage, look for HELLP syndrome. HELLP can present for the first time after delivery, and in spite of delivery, the pathological process continues. So do not let down your monitoring. Continuous monitoring of these patients for 48 to 72 hours is very, very important. Large amount of blood for transfusion must be available. You can't have one bottle of blood and say, I'm going to handle HELLP syndrome. Accidental hemorrhage is a frightening problem because the complication of AKI, the complication of DIC, all be more than double if there is an accidental hemorrhage in a HELLP syndrome patient. AKI needs to be managed actively because return of normal renal function is actually a norm rather than an exception. Mortality can occur with delayed and less aggressive treatment. So do not allow these patients to die. Do an aggressive treatment and our young patients will definitely survive. So to manage the HELLP syndrome, we need a 12-step approach: anticipate, assess maternal condition, assess fetal condition, control hypertension, prevent convulsions by giving magnesium sulfate, manage fluid and electrolytes, give hemotherapy, that is blood transfusion, manage the labor and delivery properly, give an optimal perinatal care, both postpartum and conservative, and remain alert about multi-organ failure. Finally, the role of corticosteroids is only for preventing RDS in the fetus. You give corticosteroid to a patient with HELLP syndrome to increase the platelet count. It's only an eye wash, because when I give 100 mg hydrocortisone to my patient, the platelet count will go up by 5 to 7,000 or even 10,000 for the next 1 hour or so. But after that, they're going to drop more drastically. So the use of corticosteroid for changing the platelet count is not important. I've seen many physicians ordering it. So please remember that corticosteroid is only an eye wash and is not going to help you so much. And remember, counsel the patient about all complications that could occur. Otherwise, they're going to blame you for the complications that come. They'll say, news operation sariyag madilla. That is why this kind of problem has come. So don't allow for such a situation. And use the charts to monitor the patient. The Muir's chart, which will tell you the warnings that are going to come in. Put a preeclampsia chart on all your patients so that they're monitored carefully. And if you're using magnesium sulfate, you need to put a magnesium sulfate chart for your patient. These are the minimum things you can do for a patient with HELLP syndrome. And if you have to transfer the patient, remember the steps to be taken. Patient assessment and stabilization is very important. Just don't push her out of your primary health care center if she has got HELLP syndrome. Stabilize her, give her magnesium sulfate, then only you shift her out. And write the proper referral notes, the medication administered and the investigation reports, whatever you have done. I get referral from the patients where it just says magnesium sulfate given. I do not know whether it's 2 grams, 4 grams, 10 grams, how much it is. I never know. So we should be very careful and ensure that in your referral notes, you write properly how much of each drug you have given, how much of antihypertensive, in what dose you have given. Also give her a labetalol or an oral nifedipine. Remember, it is oral nifedipine. Do not ever use sublingual nifedipine. Give her oral nifedipine and send her so that the blood pressure remains under control if she is a severe hypertensive. And of course, I told you about the loading dose of magnesium sulfate. You can all go onto the net and look for this FOGSI UNICEF protocols in OBGYN. I had the fortune of being one of the editors for this, and this particular monograph gives you everything about how to transfer a patient across to a higher center. So in conclusion, remember that both maternal and fetal life are at risk. Multiple issues, so you have to do a balancing act. A multidisciplinary approach is required. Early detection and early transfer. A high index of suspicion is required. Skilled care, adherence to protocol and guidelines. And of course, we need to do community education. Teach the couple, teach the relatives as to what is HELLP syndrome and how do you go about it. And finally, I take this opportunity to invite you all to this iShift World Congress 2023, which is being held in Bengaluru, India, for the first time in the history. And this is probably the only time we are going to have in India in the near future, because the next conference is already scheduled for Chicago, and the conference after that is scheduled for South Africa. We are going to have everyone from Leona Poon to Laura Maggie All the stalwarts are going to be there in this Congress. So use this opportunity to listen to them and learn from them. So thank you all very much for a patient hearing. And I thank Kasoga once again for giving me this opportunity.
Thank you. Thank you so much, Prakash sir, for bringing in such a wonderful presentation on HELP syndrome. And definitely we all would shudder to even think about HELP syndrome, especially on a fine Sunday afternoon. But back then it comes with a bang of any patient whenever we are dealing with, especially the high-risk units. And very extensively and nicely you have told in all the points, right from the TTP till the management of the HELP syndrome, and the various case scenarios which were so real life simulating scenarios that most of us would have come across and would appreciate when we put ourselves in that position, that very unassuming patient with very mild hypertension, suddenly she develops a bleeding, which is when we are all set aback and we sit and think about what best we could do, and the mortality rate which is so very high, and the teamwork, and especially the obstetric intensive care unit, which has to be so well geared up to understand the pathophysiological mechanisms when it comes to dealing with the patient with hypertension and HELP syndrome, and the dual-edged sword of when to transfuse and what to transfuse, and then again you end up with bleeding, which again becomes a very challenging topic to supplement the replacements which are necessary to handle such cases. Thank you so much for bringing in your expertise and the scenarios that you face in your clinical practice, and how we should be cared about it. And the last word, that the community should be educated about HELP syndrome, is what becomes so very important, because finally they blame everything on the doctor, that because you did like this, such and such thing happened. And they fail to understand that the pathophysiology which is going on in eclampsia or the PIH is so very extensive and less understood. The more we talk, the more we investigate, something new comes up every couple of years, and bang, it comes on the face. And yes, we should all be geared up, and more such classes and scenarios will help us to reinforce our knowledge as well. And I am extremely grateful that Dr. Preeti Kumar has chosen this topic and this expert speaker to highlight about the topic of HELP syndrome. And thank you so much, sir, for giving such a wonderful talk. Thanks, Preeti ma'am, for choosing this topic and the speaker.
Thank you, Dr. Rashri, for compiling the talk. Sir Prakash sir, I'm really very thankful to you for accepting the invitation. Just two, sir, queries. How long can HELP present in postpartum period? Till what time? Like 72 hours, or can it present later on also?
Yeah, most of 99% of your cases are going to come in within 72 hours. But I have definitely had HELP syndrome presenting as late as 1 week to even 10 days. But those are exceptions rather than rules. So once you finish your 72 hours, most of the time, your period of HELP syndrome is over.
Thank you so much, sir. Thank you so much.
Madhuri ma'am is here. Can we take her blessings now?
Yes, we can. Welcome, Madhuri ji. Thank you, Prakash sir. Thank you once again.
Thank you.
It was a wonderful talk. Thank you, sir. Thank you, Madhuri ji, for joining. Please say a few words and bless us.
Yeah. Thank you, Preeti, for giving me this opportunity. Actually, we were with the election opening the result of ICOG. So Preeti ji has told me, Madhuri ji, you join at 5 o'clock. So I said, we are opening the result. So I will make it, but I'll make little later. So we finished the work in the FOGSI office. And I said, let me join now. And I was very, very happy to hear Dr. Prakash Mehta. Of course, I missed Dr. Jyotsna Suri, her talk. But I'm very much impressed by Dr. Prakash Mehta. And of course, our third speaker, Suchitra Pandit, will also give her best. So I'm really concerned that hypertensive disease of the pregnancy are really making a maternal mortality rate up to 1/3 of our patient dies because of the hypertensive disease in pregnancy. And of course, how many morbidity, we really don't know. So PPH, we know that we can, 70% of the maternal mortality can be prevented by PPH if we act in a time. And even here, it has been mentioned in hypertensive disease of pregnancy, we can prevent the medical problems. We don't allow the patient to go to the, extreme stage. We can save our mothers. So here we are to discuss all these things. And I'm really happy that Preeti ji is doing with Kasoga. And Kasoga is very, very active, president, secretary, and treasurer. All three of them are very active under the leadership of Dr. Hiramat sir. who is also my mentor, that they are really doing very well. And today, Preeti ji told me it is for our members. I said, I will definitely join. And before that, she has taken for the paramedics. So that is also very, very important. The team can be only complete if you involve the paramedics, because they are the one who are going to stay with the patient. We as an obstetrician see the patient at the point of entry, admission, then accordingly we plan. But if this paramedic also knows that what are the bad things you should inform, if they inform immediately, the obstetrician is always there. Of course, in a big institute, we have residents, so they are there. But in a nursing home, especially when we are working with our staffs, they should be also aware. So Preeti ji, Dr. Thobi and, all the team, and Dr. Rishikesh Pai and Alka Pandey, I congratulate all of you for the most apt webinar and wish you all the best. Thank you once again for giving me this opportunity.
Thank you, Dr. Madhuri. Just wish to inform you that with the support of KASOGA, we have completed the trainings of the healthcare workers. We did the training for anemia, GDM, and hypertensive disorders. We finished on 5th of this month. And now from 15th, we are starting the assessments of the facility. So this webinar was for the doctor in charge of those facilities. So we just wanted to cover a few extra topics on hypertensive disorders. So probably the assessments will get over this month or maybe first week of October. So with this, we'll finish off with the Vistrit KASOGA project, FOGSI Vistrit KASOGA project, and then certification, maybe the KASOGA team will decide when to disseminate and give the certificate. And thank you so much for allowing us to do this. You are always so supportive and kind, and for all the activities which are done under Safe Motherhood Committee. So thank you so much, Madhuri ji.
Thank you, Preeti ji. You can ask me anytime for the patient care of a woman's health. I'm always there. So thank you very much. Thank you.
Thank you so much.
Thank you. Thank you, Mother.
Thank you for joining. So now next speaker, yeah. Please go ahead.
Dr. Preeti, please introduce the third speaker.
So the last speaker is Dr. Suchitra Pandit, and I'm very, very thankful to all three speakers. They are excellent in their field. Dr. Jyotsna, Dr. Prakash Mehta sir, and Dr. Suchitra Pandit, and all three of them are my favorite. So hello Lakshmi ji, hello. So congratulations for getting the new team of ICOG. So now we have our next speaker, Dr. Suchitra Pandit. Dr. Suchitra Pandit ji is very learned, a great academician. I must say, my teacher and mentor. A lot of, I can keep on talking about her, but she has served various institutions at the highest capacity, like FOGSI. She has served as president. Then she was president of ISOPAB. She was recently given the charge of presidency of Gestrosis India chapter, and she has many accolades. I think she's the only person from FOGSI who has done maximum number of presentation in FIGO conference, and we are really proud of you, Dr. Suchitra. And she has many accolades and publication. Thank you for being here. And she will speak on atypical presentation of preeclampsia and eclampsia. So over to you, Dr. Suchitra.
Thank you very much, Dr. Preeti, as chairperson of the FOGSI Safe Motherhood Committee, and Dr. Vidya Thobi, the president of KASOGA, and of course our own Madhuri and Rishikesh for conducting this particular program. And can I share screen?
Yes, you are host.
Yeah, just a second. Is my screen seen?
Yes. No. Yes.
I'm just making it. Is it full screen now?
No, not full screen.
Okay, just a second. I'll do it again once more. Now is it okay?
Yes.
Okay. So basically, I've thoroughly enjoyed both the previous speakers, because Jyotsna is, very, very passionate about the IV fluids, and it really creates a correct, exactly how should you do it. And Prakash has always been, absolutely ardent about medical problems in pregnancy. So one good thing is that Preeti has had the health topic before that, because one of the atypical preeclampsia and eclampsia problems is HELLP syndrome. So let's quickly start off with, we all know the term PIH, but now the term PIH is replaced by HDP, hypertensive disorders of pregnancy, and we all are constantly worried because this is one complication that contributes very highly to maternal and perinatal morbidity and mortality globally. And in India, many of the states now they have got a control over PPH, but they are facing problems with HDP. And we understand that now, because of the rising age of mothers, cardiometabolic disease, higher amount of ART pregnancies, obesity, lifestyle changes, gestational diabetes, excessive weight gain during pregnancy, and the long intervals that the patient have of cohabitation, they are also contributing to HTB. And we all know that preeclampsia is a serious multi-organ complication in pregnant women, and we always take standard definition as hypertension, proteinuria at 20 weeks or more. So though the incidence of preeclampsia is 10%, eclampsia is now gradually falling down to 1.9 to 2%. And earlier we would always say there should be proteinuria, but now there is this concept that the problems of the multi-organ situations, all of them get affected with a high blood pressure, even without having proteinuria. So now no longer is proteinuria is necessary as a part of the definition. And one thing we 100% must remember, that because of the syndromic nature and the various clinical preeclampsia phenotypes, when you try to find out which predictor or which particular test is ideal, it is very difficult to say who will actually develop a full-blown HDP or a HELLP syndrome. And once again, the definitions 140/90 or more, when a patient is seated, comfortable, bladder empty, it's taken by a calibrated sphygmomanometer with the right arm cuff at the heart level. And traditionally, when we talk of HDP, it includes gestational hypertension, preeclampsia, eclampsia, chronic hypertension with superimposed preeclampsia. But there are a lot more to this. Now, generally, most women will have a classical presentation of preeclampsia. That is the triad of hypertension, proteinuria, edema at or more than 28 weeks, and usually less than 48 hours postpartum. And obviously, we've all the time been saying that early recognition is important, because then only you can do some kind of an intervention and a vigilant monitoring. But when you're talking of an atypical, I'll talk to you what exactly we talk of atypical. But when you're talking of an atypical preeclampsia, there is early diagnosis is difficult because there is a great variability in clinical presentation. It may be extremely vague as a patient may just say, I'm not feeling good. Now, edema is neither considered necessary nor a sufficient investigation for diagnosis. But if it is present, we don't ignore it. But yes, hypertension 140/90 is the cutoff. But anything, say 135/85 is not entirely benign, as 40% of these hypertensions can progress to proteinuric preeclampsia. So traditional definition of proteinuria, 300 milligrams for 24 hours. But as I said before, non-proteinuric preeclampsia is not benign and may be a variant of preeclampsia. And a very interesting analysis of confidential inquiry of maternal deaths from UK, when they looked also at the eclamptic patients, 1992, it revealed that 38% of seizures occurred in women where there was no documentation of either a high blood pressure or a proteinuria. So now it brings to the mind, this is probably an atypical, and atypical preeclampsia, eclampsia. We all now must understand this line. It lacks a categorical definition, and it may include no or minimal proteinuria with no or minimal high blood pressure elevation. So the blood pressure elevation may be with or without proteinuria. So you may have different combinations. I'll just talk to you about a little later. But atypical preeclampsia develops in pregnant women less than 20 weeks of gestation and after 48 hours post-delivery, which makes them difficult to diagnose. And approximately 8% of all the eclampsia cases are atypical preeclampsia or atypical preeclampsia going into eclampsia. So sometimes this clinical presentation is associated with the capillary leak syndrome, and this comprises of a facial edema, pedal edema, excessive weight gain, ascites, pulmonary edema, proteinuria, and then you also, when you start investigating, you realize that there is a multi-organ dysfunction. So these are the patients which Prakash just mentioned a little while ago, that when you have such kind of unusual patients, admit them and evaluate them completely, particularly look at the liver as well as the platelets. So FOGSI is somebody who's worked tremendously on hypertensive disorders, and he recommends that all the patients who come with such a symptomatology of a capillary leak syndrome, where they may or may not be high blood pressure, but there is an edema, there is a generalized facial swelling, there is an ascites, ask these patients, are they having any problems, any headaches, any feeling of unwellness? And if their symptoms are there, please don't forget to do the blood test, because these blood tests can be abnormal and these patients should be labeled as preeclampsia. So what are the other presentations that can be included in the atypical category? Magnesium sulfate therapy resistance. This is very, very rare, but there are cases of atypical which do not respond to magnesium sulfate. Hemolytic anemia with elevated liver enzymes and low platelet. Typical, they could be a partial HELP or a full-blown HELP syndrome with its variants. And in the absence of a classical presentation, preeclampsia surprisingly may also imitate non-obstetric disorders. Like Prakash mentioned about the patient, they thought it was a cholecystitis, but actually it could be even a viral hepatitis, cholangitis, lupus, upper GI ulcerations, of course, gallbladder problems, idiopathic thrombocytopenia, and neurological disorders. But friends, don't forget it could also be an atypical. So FOGSI has, way back in 2006, talked about this atypical and says it comprises of 4 clinical groups. So the first group is non-proteinuric gestational hypertension, plus the presence of severe hypertension. So they may be or they may not be hypertension, or they may just have some symptoms, or they may have lab signs suggestive of microangiopathy and hemolysis. The second group, BP is normal, but they have proteinuria. They have symptoms suggestive of preeclampsia or lab signs suggestive of microangiopathic hemolysis. The third is the preeclampsia, eclampsia, or HELP that appears 48 hours postpartum, and this is something which is very, very dangerous and can cause a very high degree of maternal morbidity and mortality. And preeclampsia appearing before 20 weeks, again, this is what I just mentioned in the previous slide. So formulating a rational stepwise approach towards diagnosis is essential. So the table as per FOGSI says, gestational hypertension, I just mentioned this, but I'm just going to elaborate. Symptoms of preeclampsia, hemolysis, and remember, there may be a thrombocytopenia. A mild fall is okay, but if it is less than 100, then that is taken as critical. Elevated liver enzymes, where they are 2 times the upper limit of the normal value. Then gestational proteinuria plus one of the following, that is the symptoms: hemolysis, thrombocytopenia, elevated liver enzymes, and early signs and symptoms of preeclampsia at 20 weeks of gestation and late postpartum preeclampsia, eclampsia 48 hours after delivery. So now when you're looking at these particular results, they are typically, if you look at it, it looks exactly like a preeclampsia, because they have right upper quadrant or epigastric pain, retrosternal chest pain, nausea, vomiting, a feeling of illness, shortness of breath, headaches which are not responsive to analgesics. Sometimes there could be an altered mental status, visual blurring, bleeding from mucosal membranes, jaundice. All may not be present, just one of them may be present. So the lab test, if there is a persistent proteinuria, if the platelet count is showing a downward trend, if the SGPT, SGOT are twice the upper limit of normal, if the creat is showing a higher value, and if the LDH levels, please never forget to include LDH. Lactic dehydrogenase is 2 times the upper limit of normal. All these are pathognomonic of an atypical preeclampsia. And remember, friends, the syndrome of preeclampsia in the absence of proteinuria should be considered as gestational hypertension. And if this is having persistent symptoms or abnormal labs, remember 25 to 50% of these patients can progress to a full-blown preeclampsia. And of course, the rate of progression will depend upon the gestation age as to when the hypertension has occurred. But if the hypertension has occurred earlier, then the rate of progression is very, very fast. And majority of the times they will affect the fetal growth. They may cause a preterm delivery. And these are the women we have to be very, very careful. Strict, vigilant observation, monitoring these patients in probably a tertiary care unit, or in a place where you are able to give them frequency of not just visits, but serial evaluation of platelets, liver enzymes, as well as serial ultrasound, because they can suddenly catch you, as Prakash had mentioned, a case of abruption at 29 weeks of gestation. So then patients who are having all these symptoms and abnormal lab tests with abnormal lab findings should be considered as having atypical preeclampsia and start treating them. But the results from the uterine artery Dopplers may have no prognostic value regarding the timing of delivery. But investigate them for diabetes, for undiagnosed lupus, because anticardiolipin antibodies, the serology, the platelet counts, undergo a metabolic profile, complete urine analysis, look at the ECG, the 2D echo, and the 24-hour urine. Today, we are, instead of 24-hour urine, we are doing the PCR, that is a protein clearance. And obviously, you don't do renal biopsy in pregnancy because the results are not going to be helpful in the treatment. But if you're thinking in terms of a renal disease, please monitor this patient vigilantly for her urine outputs, her creatinine, as well as the blood pressure. And these patients should be considered at a severe risk for development of future preeclampsia, and therefore manage them vigilantly and call them much more frequently. So this is that typically capillary syndrome leak which I was mentioning. They could be either normal, they could be mild, they could be severe, that is a blood pressure. They could have a typical full-blown picture of health. They could show signs of renal failure, low platelets, elevated liver enzymes, or even they could have a DIC. And symptomatology-wise, yes, as we mentioned before, the epigastric symptoms, CRS symptoms, vomiting, the facial and the pulmonary edema, the ascites. This is a typically capillary leak. And all these are again mentioned in Bahai Sibai. It's a very nice monogram which is written by him way back in 2009. Now, atypical forms of eclampsia have erratic onsets. So therefore, if you make a correct diagnosis, probably you will be able to initiate a timely therapy, and it is difficult. Sometimes, you're completely called off guard, but if you don't treat them, these are the very women who will have problems. So therefore, we all need to increase awareness with our paramedical staff also of the non-classic and the atypical features of preeclampsia, eclampsia. And now we are finding these on the rise. So we remember that some of these women may have typical features and some may not have typical features, but multimodal screening is very, very important. And I'll talk to you about the screening a little later, but the stepwise approach is very important. And remember, in the epidemiological and the clinical concept, whenever hypertension sets in earlier, the problems to the mother and the baby are a lot more, and there's a very high incidence of abruption. Again, we must remember that significant proportion of such women may not demonstrate any signs of preeclampsia and may suddenly start convulsing. And this is what we talk off as unheralded eclampsia, no premonitory signs. And what is the problem with the seizures? They lead to neurological damage, severe maternal hypoxia, trauma, aspiration pneumonia, and this permanent white matter loss can lead to clinical neurological deposits. And of course, when you're talking about differential diagnosis, I know all these are there. You talk of hemorrhage, ruptured aneurysm, cerebral venous thrombosis, encephalopathy, angiomas. You have the intensivists who will talk about all these, even metastatic gestational trophoblastic disease. This is important. Just note this particular point, because in the next slide, I'm going to tell you, we already know that with a molar pregnancy, one can have an atypical preeclampsia. So gestational trophoblastic disease, which goes unnoticed, can lead to this particular problem. And of course, metabolic diseases, reversible posterior leukoencephalopathy syndrome, TTP, and post-dural puncture syndrome and cerebral vasculitis. So gestational proteinuria, again, coming back, I'm repeating this sentence, but why am I repeating is, please follow these patients carefully, as they have a risk of developing typical preeclampsia, and therefore careful monitoring, constant questioning may help prevent morbidity and mortality for this particular case. So what is the plan? Then the way to investigate is assess all the maternal risk factors, clinical lab imaging findings, the time of onset in relation to the gestational age and delivery, and a risk factor was also found, oocyte donation primiparity. We had gone through this particular article when we were formulating the gestosis score, and I'm going to talk to you about that just a little later. But remember, all these add up to the atypical presentations, and if this patient starts getting the capillary leak syndrome, you can be almost sure that they will end up having some kind of a multi-organ dysfunction. So therefore, in these patients, please don't forget to do an ultrasound, first to exclude either a twin pregnancy or a partial mole or a complete mole or a mole with a twin pregnancy, and check for cystic degeneration of the placenta. So goes without saying, a complete blood count, which includes platelet counts, liver function tests, LDH, and wherever possible, if you have a disintegrin-like and metalloprotease with the thrombospondin, it should be considered to rule out TTP. And in the bigger centers, these tests will be available, but LDH is available at all places. And then the APLA syndrome, please don't forget to check those investigations. An anti-nuclear antibody screen, anti-mitochondrial antibodies, serum serology for lupus and serum biochemistry. Don't forget to diagnose lupus, because typically lupus presents at 27 to 28 weeks with a sudden high blood pressure and abruption. And of course, a PCR and renal test as I've already mentioned before. Now, uterine artery Doppler velocimetry is important, because whenever there is an increase in the resistance index and pulsatility index and the presence of a protodiastolic notch, it may predict the development of preeclampsia. And once you have diagnosed it, please discuss with the family and the patient. This pregnancy should be terminated once the patient is stabilized, unless you feel that the patient needs, she's much better, she's improving and responding to your treatment. Do not wait. I will show you the protocol of management of such patients. The management is identical to that of classic preeclampsia, where the choice of therapy and decision to deliver are guided by the presence and absence of signs of gravity. Now, I'm not going to go into details of the drug therapies, but you have labetalol, nifedipine, nicardipine, alpha-methyl-dopa is no longer available, but these same drugs are available also as an IV, particularly IV labetalol is there. Oral nifedipine is there for the severe things, and IV nicardipine is there. Hydralazine now also is available to the gynecologist for treatment. Oral as well as the IV hydralazine is available. The magnesium therapy protocol, depending on whether you are using Pritchard's or Zuspann's regime. Fluid management, as Jyotsna Suri is very beautifully elaborated. and timely delivery once patient stabilizes. And even after she delivers, vigilant monitoring of the blood count, platelets, electrolytes, liver enzymes, and renal function tests. So this is the traditional care plan that we follow. Anyone less than 25 weeks. So obviously, if it is less than 20 weeks, you stabilize the patient and consider termination. If it is a severe high blood pressure between 25 to 33 weeks, you do have time for expected management, but this should be done in a tertiary care center. Give steroids, role of Maxel for neuroprotection. But if she is a HELP syndrome, please don't sit on her, deliver her. And more than 34 weeks, stabilize and deliver. Many times people have asked me the question, if there's a severe preeclampsia and she responds to your medication, she has shown features of an atypical variety, should you wait till term? No, you should not. Stabilize her, send her to a tertiary center where there is a good NICU, and after 34 to 35 weeks, consider delivery, particularly if you feel her values are borderline and she has shown once a picture of atypical preeclampsia. So atypical patients, as I said, tertiary care. Why tertiary care? It could be multidisciplinary, where you have a well-equipped labor room, good lab support, HDU, ICU, and a neonatal ICU. Of course, less than 23 weeks, 24 weeks, you cannot even salvage the fetus. But anyone which is 25 to 26, a place like Surya or where there's good NICU, we can still salvage those babies. So what are the antihypertensives? What is very important is the choice will depend on the obstetrician's experience, correct dosages, rational combinations, and stabilize the blood pressure and avoid hypertension. But remember, you can give nifedipine plus Maxel. Maxel alone is not an antihypertensive, it is an anticonvulsant. Over a period of time, it causes peripheral vasodilatation, but that is not an antihypertensive drug. And you cannot use ACE inhibitors, atenolol, beta blockers, or diuretics if the pregnancy is over 24 weeks. But if it is less than 20 weeks atypical, you're allowed to use these drugs because you've decided to terminate the pregnancy. HDU is important. It has to be there because you can monitor these patients. You have all the ways of monitoring these critically ill patients. You don't have to put them in an ICU, and it will avoid exposure to the critically ill patients, and patient satisfaction rates are much more better as it is less noisy. But friends, you have to remember that for monitoring such patients, you have to have access to ICU, particularly if they develop a HELP syndrome, severe pulmonary edema, liver issues, neurological dysfunction, refractory hypertension, or DIC, or renal failure. All these patients will have to be, you have to have a multidisciplinary management and shift these patients to the ICU, because there you can have a monitoring facility and simultaneously you can manage the patient there. So if we are talking of atypical, today there is so much of work done on prediction of preeclampsia. What about atypical preeclampsia? Don't we have a predictor? Well, I'd like to say something. Newer early detection strategies are being developed day by day, and the whole idea is to prevent preeclampsia. So if we can try to identify with a multimodal screening which patients are at risk, why not try that? And the topmost is dystosis score. Then we have ultrasound with Dopplers, we have biochemical and angiogenic biomarkers, and with this we can actually use low dose aspirin in the first trimester itself. And dystosis score, I'm sure you all know about it. It is a score coming from the dystosis score group. And Dr. Gorak had developed the dystosis HDP app also. We've already validated this study. And this is, I'm sure you all know, this is all available on the website, 27 morphological characteristics. And I just want to draw your attention to the left side. We are looking at excessive weight gain conceived with ART, PCO, chronic vascular disease. All these merit a point of 1. And if there is an egg donation or a surrogacy, all these merit point of 3, including mental health issues. And of course, gestational diabetes is a part of metabolic syndrome, maternal hypothyroidism, family history of preeclampsia. All these get a point of 2. So if you get a score of 3 or more, these patients are at risk, and don't hesitate, just start low dose aspirin, 75 milligrams is what we recommend, and calcium 1 to 1.5 grams. And please mark these patients with a red card or a pink card or whatever your way of managing is, and call these patients back frequently. The HDB gestosis score is available on the Android phone. Download it from the Play Store, make printouts, make charts, and use this. Very easy to use. Ultrasound, yes, this is again a part of the screening tool, and we know that if the uterine artery resistance increases, then we calculate the mean PI, that is a pulsatility index, and if it is more than the 95th centile, these patients are at a high risk for development of preeclampsia. Diastolic notch is no longer considered, but at the first trimester, when you're doing a nuchal scan, dual marker, you can add a PLGF, placental growth factor. It is available. Some of the companies have come forward with that. So when you see these values later on, if the PAPI is less than 0.5, you know it's predictive of some kind of placental dysfunction, which will lead to FGR. But umbilical artery Doppler is the best predictor. So when you combine the maternal factors, the mean arterial pressure, and the uterine PRAs, you can actually improve detection rates from 36 to 59% with a false positive rate of 5%. And of course, then you have your biochemical markers, the PAPI, as I've already mentioned about that, the placental growth factor. PAPI everybody knows, but I would like to tell you that if you do a first trimester PAPI and a second trimester S-FLIT by PLGF ratio, that is a placental growth factor, it could actually predict late onset preeclampsia. But if you combine the PAPI along with the placental growth factor in the first trimester screening itself, it will give you a risk ratio of development of preeclampsia, early preterm preeclampsia. So that would put a tick mark in your mind. And placental growth factor, we all understand that it is involved in trophoblastic invasion of the spiral arteries. So if the values decrease, you know that there could be aneuploidies, there could be placental impairment. And in the second and the third trimester, you know these patients could develop preeclampsia and fetal growth restriction. And now these are available at most of the places. So when you look at the combinations, if you see this particular combination, the maternal factors, mean arterial pressure, uterine artery P and PLGF give you a detection rate of 81% for preeclampsia less than 37 weeks. So this is a good test, and when you combine all of them, it again gives you the same. So this seems like a very good method, multimodal screening as it is called. And I won't go into details of the Fetal Medical Foundation, the ASPIRATE trial. This combines the a priori risk as well as the biophysical and biochemical parameters. And they have clearly shown that if you give aspirin compared with placebo in the two groups that they took as trial groups, these resulted in 62% incidence of preterm preeclampsia, but they did not have much of a significant effect on the incidence of term preeclampsia. So yes, wherever possible, this as per these trials, this could be offered to the patient, where they're looking at the maternal morphometry, they're looking at the blood values and the Dopplers. But remember, you need a lot of expertise for this. NICE guidelines, ACOG guidelines, ASPRI, all of them say the same thing. ASPRI is much more better as compared to the NICE or the ACOG. But let me tell you, in a country like ours where you don't have access, unless somebody is really good at this scanning, use the gestosis score, very, very promising. And remember, you also have the angiogenic biomarkers. I just mentioned about this. The S-FLIT to the PLGF ratio is a very valuable aid in diagnosis of preeclampsia and discriminates between different types. But this is a little better for patients who are above 28 to 32 weeks. So if the value of 38 or lower is there, it can predict the absence of adverse fetal outcomes within 1 week. But if you combine the PLGF with the first trimester screening, they will actually give you a very nice percentage, and they will say low risk for development of severe preeclampsia less than 37 or more than 37. So this is the value of this particular thing. So therefore, for the preterm and the term preeclampsia, you can adopt this S-FLIT to PLGF ratio in clinical practice. Not very expensive. Currently in Mumbai, it's available, costs around 2,000 rupees. But I'm sure when the demand increases, the supply will also automatically tell. Now, just going on to the last few slides, where postpartum period is a time very, very high risk for preterm or for preeclamptic convulsions. So for the first 3 days, monitor these patients, look at the BP every 4 hours whilst they're awake. Sometimes hypertension worsens postpartum, particularly day 3 to day 6, and many a times a severe hypertension manifests first time after delivery. So please continue antihypertensives, and if you feel you've not given Maxil, even now you can give Maxil. So gradually reduce the dose of antihypertensive therapy, and if you feel that this patient requires some analgesics, avoid non-steroidal analgesics. Remember, these patients could have an underlying kidney problem, and essential to screen all these patients. Look at APLA at this time. If you feel the BP is persistent, investigate them with the cardiologist, do your lipids, glucose, and standard 12-lead ECG. And if you feel everything is okay, call the patients back at 3 months to ensure the BP is normal. But if you feel that the proteinuria, hypertension persists, please call for reference to the nephrologist and the cardiologist, because these patients can end up having long-term cardiovascular problems and chronic hypertension. Another very important thing is discuss about contraception with them, because you don't want them to get them pregnant. They may be depressed, so talk to them about positive health issues, and counseling may be necessary to reduce the post-traumatic disorder. Sometimes because of atypical preeclampsia, they've lost their pregnancies, so they want to conceive again, but you have to counsel them, change of lifestyles, and get them to monitor before they get pregnant again. Now, very, very important is sometimes the patients develop a health syndrome post-delivery, and Dr. Preeti had asked that question, how long do we keep taking, how long do we know? Till 7 days post-delivery, the patients can develop a health syndrome. So please, if you have not done the investigations before, do all the platelet counts, liver enzyme tests, and coagulation studies, rule out the secondary problems, and look at even acute fatty liver or pregnancy or hemolytic uremic syndrome. So involve your intensivist, summarize, the case, and know that the definition could also include preeclampsia. Avoid overdiagnosis, but avoid a misdiagnosis. And late postpartums are the ones which are very, very dangerous. Sometimes the patients can suddenly convulse. They've gone back home and they've come back to you with convulsions. So remember, friends, don't just ignore these patients. If you feel there's a red light somewhere, there's a red flag somewhere, please stop, investigate the patient, and aggressively investigate them, because approximately 20 to 30% of women with HELP syndrome can experience manifestations and can convulse first time at 48 hours after delivery. And HELP is an atypical preeclampsia. So don't forget the differential diagnosis. And one last complication which I want to tell you, which is not very uncommon. This is the classical preeclampsia, eclampsia, posterior reversible encephalopathy, which can come on with atypical preeclampsia as well as with HELP syndrome. Suddenly the patient comes in with convulsions, unexplained blindness, neurologic deficits, and probably the differential diagnosis could be the Press syndrome, but ask for an MRI and a cerebral angiography. You could give them corticosteroids, let the intensivist also be there to decide what exactly you want to do. But the Press syndrome, it is reversible, so don't give it up. There is a sudden rise of blood pressure, headache, visual deficits, loss of vision, altered sensorium. The patient can come and also with convulsions, and they could be severe preeclampsia, hypertensive encephalopathy. But remember, the MRI is a gold standard, which will tell you typically, the figures which come up over here, the typical punctate or confluent symmetrical bilateral hyperinsensitivity in the parieto-occipital globe. So what is the treatment? There is a vasogenic cerebral edema, there is hypertension, and the patient is having neurological problems. So discontinue the offending medication, lower the blood pressure, treat the seizures with Maxil. If you feel she's not responding to Maxil, phenytoin, benzodiazepam, sometimes valproate is also used, and mannitol to reduce the edema. These patients have to be in the ICU, correct the coagulopathy and the low platelet count, and sometimes you may even need to do a temporary peritoneal or hemodialysis. But let me tell you, after 4 to 5 days, these patients show a visible improvement. So friends, in conclusion, I'd like to say, preeclampsia is a syndrome with varied manifestations. So widen your spectrum and tell yourself in the mind, tell your staff members also, you don't want to overdiagnose. It's better to be on the side of caution. Obtain a detailed history, use the gestosis score, do the targeted labs test. You can definitely use ultrasound, but in the first visit, when the patient comes to you, gestosis score is easy to do. And friends, an astute clinician will always keep in mind the atypical forms, because this is where we get caught unaware. Because once you have that index of suspicion in your mind, start treating them, give them that vigilant monitoring, and avoid the increasing maternal perinatal morbidity and mortality. And thanks very much, Preeti. Thanks for including this topic, because there is very little literature at one glance. I had to review almost 15 sessions and chapters, and this chapter by Bahaya Sibai is the one which was most elaborate. Otherwise, most of them are case reports. I did not include case reports over here because I thought, let me give you a little more detailed history about and how to investigate. And once again, thank you very much for.
Thank you, Suchitra ji. You have given new insight to this topic. Actually, we also learned many things. And we would like to have these PPTs because these are important for the facility in charges, because some people have asked for the recording. But anyway, there is one question for you. That is on the what is the experience with intercurrent pregnancy, continuing pregnancy till 36 weeks if patient is stable post magnesium sulfate?
Okay. If the patient has developed convulsions, there is no way you should continue the pregnancy. You give the necessary anticonvulsant therapy, the antihypertensives, and consider terminating the pregnancy, whatever period of gestation. So there is no role in the current, whatever data that we have of intercurrent eclampsia. But if the patient has got severe preeclampsia and you are able to stabilize her, and she is between 28 to 33 weeks, you can stabilize her, you can shift her to a tertiary care center, you can give her magnesium sulfate because it also gives a neuroprotective dose and also prevents the imminent eclampsia, and also you have time to give her corticosteroids. Meanwhile, very vigilant investigations, and the day you find something is going wrong, either maternally or fetal wise, please terminate the pregnancy. But there is no role of conserving a pregnancy in intercurrent eclampsia. There is no such term today. Now we don't accept it at all.
Thank you so much, Suchitra ji. There are so many comments regarding your talk. Excellent presentation as always. And all the three speakers today were excellent, and we are really lucky to have you all today for this wonderful session. Dr. Rashi, your comments, would you like to say something?
Ma'am, as usual, it is always a pleasure and a joy to listen to Dr. Suchitra Pandit, and especially on her expertise of dealing with the topic of preeclampsia, eclampsia. And I'm so grateful that Madam has accepted to address the facilities today, because as you have rightly mentioned, the facilities are very eager to enhance their expertise while dealing with such case scenarios, because this is about the preparedness of the centers, and this completes the entire purview of what we were trying to imbibe upon the centers, because having been trained with the basics now, I am sure with these three fantastic topics today, they have more confidence to get, as Madam has rightly said, it's all right in a big center dealing with the ICU setup and all, but our facilities are the grassroots level kind of facilities wherein most of the doctors are involved in providing the healthcare with maybe the level 1 or level 2 kind of facilities available in obstetric care. So thank you so much for taking up these topics, and excellent coverage of all the three designated topics, I would say, because we would really like to know how to manage with the IV fluids. We would really like to know how to manage with the HELP syndrome. And last but not the least, the atypical kind of eclampsia, as Madam has brought in the entire range of unusual situations. And thank you so much, Suchitra ma'am, for accepting and giving us these talks and enlightening on this Sunday evening. I think it's been a very fruitful Sunday evening for all of us. Thank you so much, Preeti ma'am, for asking me.
There are a few more questions, Suchitra ji, for you.
I just want to mention one thing. That, many a times what happens is patients move from one facility to other. They'll show somebody once, then they'll go somewhere else. They'll keep moving around doctors. Those are the patients who will suffer the most. So in the first visit itself, we must try to, impress upon the patient, where are you? If you're going to go to your mother's place, go in time. Yes. Otherwise, majority of the times if they're moving, because we've had a patient of Press syndrome, she's moved around with 6 doctors and finally landed up with us as a Press syndrome. And it was because her husband was traveling. She was also traveling with the husband. So somewhere we have to impress upon them. And please, because it's a primary, secondary healthcare facility, use the Gestosis score. And yes, I saw one of the questions was, can you use Maxel second time? No, there's no, once you've given the full dose. And remember, when you're giving Maxel for prevention of preeclampsia, for eclampsia, you're giving a 24 hours full schedule, the same dose you're using even for neuroprotection. But if you're using it exclusively in preterm labor for neuroprotection, then you should use it when the delivery is imminent, and that time you give it only for 24 hours. But there is no rule of giving Maxel again. And yes, post-delivery, you can use ACE inhibitors for control of blood pressure if the standard antihypertensives are of no use. Post-delivery, you can use it, but in the antenatal period, you cannot. But in a case of an atypical preeclampsia coming in at 20 weeks, where you've decided to terminate the pregnancy, you can give Maxel, and here you can use ACE inhibitors. But where it's a viable pregnancy and you want to deliver the patient, there obviously you cannot use an ACE inhibitor. But you have now, along with the nifedipine, you have IV nicardipine, plus you have IV hydralazine when the BPs go very, very high. So those. But
Suchitra ji, if it is early before 20 weeks, suppose the case of gestational trophoblastic disease, can we use inhibitors in those cases?
Yes, you can. You can.
Okay.
Because you're terminating the pregnancy.
Yeah. Anshu, there are a few more questions. Can you take a few questions? I think there's one question on.
Ma'am, can I ask one question, please? Can I ask one question, please?
Yes, sure.
Yeah, Dr. Go ahead, Anshu, please ask the last question.
Yeah, Suchitra ma'am, sometimes when we have these patients with high risk obstetric like IVF pregnancies, and they have had a convulsion at around say 28 or 29 weeks, there may be a scenario wherein you would like to continue the pregnancy after stabilizing the eclampsia. Isn't there any role to continue the pregnancy in such scenarios?
No. Once eclampsia, then you have to terminate.
Deliver her. You have to deliver her. Unless her convulsion is because of an epilepsy, or it is because of some brain, small little lesion in the brain like cysticercosis or tuberculoma, but then you have to prove it. You have to do an MRI, make sure it is not eclampsia. But if it is eclamptic convulsion, please do not.
You have to terminate. Yes.
Irrespective of the period of gestation.
Yes.
And without even waiting for 2 weeks or 4 weeks.
Because every convulsion is going to cause a neurological deficit and damage to the brain white matter of the patient. So now please do not continue.
Yes.
There is just one question, that for how long should we use the antihypertensive drugs in the postpartum period?
Okay. In the first 3 days, if the patient has been very severe hypertension, you monitor the BP and gradually titrate the dose and taper the dose. But if you find that even after 3 days, the BP is not coming down, please don't discharge her. Keep the patient in and titrate the dose unless she is intelligent enough to have home BP monitoring, or she has a family physician visiting a house checking the BP. If after 7 days, the patient's BP has not come down, most of the time this patient is going to go into a chronic hypertension, which is labeled. So then you have to change the blood pressure medication. You can switch over from labetalol. You can probably give her amlodipine, or you can, take a physician's opinion and decide to give her an ACE inhibitor. But by that time, you should have done an ECG and a 2D echo. And don't forget, all these patients with hypertension Do not forget to do an ECG and 2D echo in the antenatal period and repeat it even later, because these patients, and sometimes we may think they're chronic hypertension, but what is the cause of the chronic hypertension? Is it essential? Is it related to a connective tissue, or is it related to the kidney? We must be able to find that out. Many times these patients are obese, even obesity, all these things go hand in hand. So we have to think of lifestyle changes. So call these patients back more frequently. Kabhi-kabhi kya hota hai na, they think अरे delivery हो गई है, सब भूल जाते हैं. Suddenly on the 7th day, we've had, when I was working at Sign, 7th day the patient has come back convulsing, and those then become very difficult to manage. Those are more dangerous, those convulsions.
And there is one more question, that any standardization of Lasix for capillary leak syndrome?
No, there is no standardization. Normally, we don't like to give any kind of a furosemide. But if you find that there is a pulmonary edema, there is an this patient obviously needs to be in the ICU. You have to put a CVP line and then give them one shot, 40 milligrams of furosemide is okay. But if you have to give it on a continual basis, you have to have the patient under an intensivist, because then you do a serum electrolyte monitoring, do a CVP monitoring, and only then you can give furosemide. Because otherwise, if you're going to give it, it is going to be more harmful to the patient. So therefore, unless you're giving it just one shot, doesn't matter. But if you want to give it on a regular basis, please decide your plan of action. What do you want to do? You're deciding to terminate the pregnancy, then it's a different situation. If you're going to continue, if she's got a capillary leak syndrome, she's got severe hypertension, she's coming with convulsions, then you've decided to terminate, yes, you can use furosemide. But don't use it lightly, because all these patients already have a contracted third space. So by putting in furosemide, you can have more of an aggravation of the problem. So unless you've done a CVP monitoring, don't just give them furosemide.
One more
Thank you,
question. I think can you read out one more question? If there is one more question, Suchitra ji, please clarify that. If a blood pressure is more than 160 by 110.
Yes.
This is a question. Should we give magnesium sulfate in all cases or only in cases with impending signs of eclampsia?
No. If anytime the BP is 160, 110, you give Maxelf, but you must also make sure you're given an antihypertensive. So as the Maxelf is getting loaded, please give her your antihypertensive. Start the IV line, give her labetalol, give her an oral. If you feel she's conscious and fine, give her an oral nifedipine. Otherwise, start off with IV labetalol. Lower her blood pressure gradually, but you must give her Maxelf. You can stabilize the patient once you've given the Maxelf, because anytime the patient is 160, 110, she can start convulsing at any time. But let me tell you, even at 140, 90, we've seen patients convulsing. But then those patients, probably their BP initially has been missed. They've come to us, some medicine has been given to them, so the BP has come down and these patients have started convulsing. So Maxelf is a very nice drug. Give it, because it is an anticonvulsant. It reduces the cerebral edema, cerebral irritation. Give Maxelf to the patient. But once you give it, please give it completely for 24 hours. And you follow the standard protocol of, the urine output, the patellar reflexes, and the respiratory rate. These clinical indicators are good enough. Only in ICU setups and where facilities for biochemical monitoring and the serological monitoring are available, that's the only time when we do the serum electrolytes and all the others. But otherwise, clinical monitoring is good enough. But as Jyotsna Suri has said, manage the IV fluids, give the Maxels, give the antihypertensives, and then decide, once the patient is stabilized, what do you want to do? Do you want to continue this pregnancy? What is the status of the pregnancy? Is she term? Do an internal examination, but don't jump and do an internal examination or even a catheterization unless the patient has been stabilized. Once she's stable, then you do in your catheter, get the urine output, and then give, then you decide what your mode of plan, whatever the plan is. But if you feel, 29, 30 weeks and she's remote from term and you feel it is impending, there are problems, by the time all your blood profiles have arrived, your liver profile, your platelet counts, then you decide what you want to do. Whether you want to wait for a normal delivery, whether you want to do a Caesar, but the blood parameters will also, in case this patient happens to be a HELLP, don't jump in and do a Caesar because you'll have more of a problem on the table. As Prakash Mehta very clearly said, get all your blood values, order for your blood products, and in any busy maternity, there is always adequate amount of blood products. Order for them and call for help because you need multiple people to manage all this. Then you decide what you want to give, because by then you've got all your parameters, and then you decide. But never ever rush and do a HELLP. And again, one more thing I'd like to tell you, if you find that the patient is in imminent labor, 4 to 5 centimeters, and there are signs of HELLP, please give her the blood products and allow a vaginal delivery. No problem at all. But if you feel it is coming atypically at 28, 30 weeks, don't wait and conserve. LDH levels go so high and the patient can suddenly deteriorate and go into a DIC. Get all your blood products, stabilize the patient, get the adequate platelet count, and then, consider delivery.
And there is one more question.
Yeah.
Can we give Maxelf in severe preeclampsia with pulmonary edema?
Maxelf, yes, there is no contraindication. There is absolutely no contraindication. But address the pulmonary edema, find out what the cause is. What is the cause? Maxelf will not harm it.
But there would be respiratory distress,
Yes,
Sujitra-ji, during pulmonary edema?
Yes.
So,
Should
we give?
No, if it is known, 1 second. In the initial phases, let me just clarify this. In the initial phases of pulmonary edema, the patient may start getting dyspneic. But if it is an overtly blown out dyspnea and the respiratory rate is low, obviously then you don't give it. So
Yes.
you investigate that. But if it's just a capillary leak syndrome, which is just started off and the patient has got, just signs of few basal crepes, then there is no harm in giving Maxelf. But if it's an overt pulmonary edema, obviously the patient is, your respiratory rate is going to be very, very, it's you just cannot give her anything. Stabilize the patient, and that is the patient where you need to give furosemide. But please get your intensivist involved by that time.
One more question, Sujitra-ji, I think the same question. Can we give just 4 gram of magnesium sulfate with 160, 110? I think we have clarified this point.
No. If you're giving, give the 4. But there is a role if you're shifting the patient to a tertiary care center and you don't want to give the entire IV, you can give them the intramuscular dose and let the patient go, or give her the loading dose of 4 grams IV slowly and give the intramuscular dose of 5 grams and let her travel wherever you have to travel.
Thank you. I think Sujitra-ji has answered all the questions.
But what
Thank you so much,
the transfer notes are very, very important, particularly in the receiving center. You don't know what has been given. So sometimes you're really wondering because there's nothing written on the paper. So
yes, that's very important.
Yeah, very important.
Yes. Thank you so much, Sujitra-ji.
Thank you, ma'am. I thank all the speakers and the chairpersons for a wonderful session. And shall I now proceed with the vote of thanks, Preeti-ji?
Yes, Anshu, please go ahead.
So after the excellent talks by esteemed speakers, it's time for vote of thanks. And I would like to thank all the FOGSI leaders, Dr. Rishikesh Pai, our President, our Secretary General, Dr. Madhuri ma'am, who's always there to guide us, Vice President, Dr. Alka Pandey ma'am, and the Dean ICOG Case Kasoga, Dr. Hema Divakar ma'am, and our dynamic and visionary chairperson, Safe Motherhood Committee, Dr. Preeti Kumar, for whose brainchild is this initiative. And this wouldn't have been possible without the support of the Kasoga, team Kasoga, which is led by respected Dr. Hirimat sir, and our guiding light, Dr. Vidya Tobi ma'am, Dr. Rajshri, Dr. Suman, and ever smiling and helping Dr. Shobha. I would like to thank all our learned speakers, Dr. Jyotsna Suri ma'am, Dr. Prakash Mehta sir, and Dr. Sujitra Pandit ma'am for their enlightening talks. And I would also extend my thanks to the chairpersons who took out time on a Sunday evening for chairing the sessions. Thank you, Dr. Vidya ma'am, Dr. Rajshri, and Dr. Preeti Kumar for chairing the sessions. A special thanks for the attendees who joined in today. And thank you, Dr. Parul Gupta ma'am. She's my co-convener. And a big thanks to the technical support team who were flawless in the execution of the session. Thank you, everyone, and a very good Sunday evening to all of you.
Thank you, Dr. Parul, and thank you, Anshu.
Thank